Okay, let's unpack this. We're about to dive into a condition that sounds almost, well, unbelievable in its severity and challenge.
It really is.
I mean, it accounts for 1 in every 1,000 hospital admissions. It affects roughly 9 out of 100,000 Americans.
Which sounds maybe rare, but when you see the impact.
Exactly. And here's the stark reality. Despite all the incredible medical advances we've made, its mortality rate is still stubbornly high. We're talking 30% to a staggering 90%.
It's a brutal condition. It's called mesenteric ischemia. And basically, at its heart, it's when the blood flow to your intestines drops below the critical level needed for the tissue to just, well, survive and function.
And that shocking mortality rate, like you said, it often boils down to one key challenge.
Yeah.
Diagnosis.
Yes. Or, more accurately, delays in diagnosis. It's incredibly complex to spot. The symptoms can be tricky, and the stakes just couldn't be higher.
Right. You've shared some really, really detailed medical texts on this subject, getting right into the nuts and bolts.
Uh-huh.
So our mission in this deep dive is to kind of cut through that density, pull out the essential insights, and help you understand what mesenteric ischemia is, why those few crucial hours make all the difference.
Absolutely critical.
And how the medical world approaches trying to diagnose and treat it.
Exactly. Let's do it.
So let's start with the foundation, the incredible plumbing system that keeps your gut alive.
Absolutely. Think of your intestines as needing a superhighway network for blood. You've got 3 main arteries that supply most of your GI tract.
Okay.
And then a parallel system of veins to drain it all away.
And the big 3 arteries are the celiac axis, the superior mesenteric artery, SMA, right?
That's the one, SMA. And the inferior mesenteric artery, the IMA.
Got it. Celiac, SMA, IMA.
That's right. So the celiac axis, it's the shortest one. It takes care of the upper part of your digestive system, your stomach, liver, spleen, pancreas, and the very beginning of the small intestine, the upper duodenum.
Okay, upper section. Then the SMA, that's the big one you said.
It is. The superior mesenteric artery is the largest and arguably the most critical for the bulk of your gut. It supplies the midgut.
Leeches.
The rest of the duodenum, the jejunum, the ileum, that's pretty much all of your small intestine, and then a significant chunk of your large bowel, all the way up to what's called the splenic flexure on your left side.
Wow. Okay, so it covers a lot of ground.
A huge amount.
And the IMA, the inferior mesenteric artery.
That's the smallest of the trio. It handles the blood supply for the left side of your colon and most of the rectum.
Okay.
And all the blood that goes in via these arteries, well, it eventually drains back out through a network of veins that feed into the portal system heading towards the liver.
So that's the basic map, the highways and byways.
Right.
But you mentioned the gut's blood flow isn't just simple plumbing. It's got unique features.
It really does. The mesenteric vessels are surprisingly dynamic. For instance, after you eat a meal, blood flow to your intestines just skyrockets. Oh yeah. The SMA especially experiences what's called hyperanemia, a huge increase in flow about 20 to 30 minutes after you've finished eating. It's basically the gut powering up for digestion.
Makes sense.
And your gut lining, the mucosa, it also has this clever ability called autoregulation. It can try to extract more oxygen from the blood when flow is getting tight. It's like a last-ditch effort to stay alive.
Clever.
And the whole system is constantly being fine-tuned by your nervous system and, hormones.
Okay, so you've got this sophisticated responsive system. Here's where it gets, well, really interesting and, frankly, terrifying. What happens when, despite all that, the blood flow isn't enough? What's actually breaking down at the tissue level?
Right. The outcome of insufficient blood flow isn't simple. It's this complex cascade of events. And it's not just the initial lack of oxygen that causes damage. That's the ischemia bit.
Okay.
But sometimes, paradoxically, even restoring the flow can cause new problems. That's reperfusion injury.
Reperfusion injury.
Got it.
And the sources point out which part of the gut is like the canary in the coal mine. The most vulnerable.
Yes, absolutely. The mucosa, that very inner lining of the intestine, it's the most sensitive. Damage to this layer, things like sloughing, ulceration, bleeding, that can start within a mere 3 hours of blood flow being cut off.
Just 3 hours. Wow.
Yeah. And if the blockage is severe enough, the tissue death can extend right through the entire wall of the bowel. That's called transmural infarction.
Transmural. Through the wall.
Exactly. And that can take anywhere from 6 hours to potentially several days, really depending on how bad the blockage is.
And that initial damage to the lining, the mucosal breakdown, that's the critical turning point, isn't it?
It absolutely is, because once that protective barrier is breached, the contents of your gut, including, trillions of bacteria, can leak into your bloodstream.
That sounds bad.
It's very bad. It triggers a massive inflammatory response, increases the leakiness of your tiny blood vessels, the capillaries, causes widespread swelling or edema, and it can rapidly lead to multi-organ dysfunction or even complete failure throughout the body.
Yikes. And then you mentioned that even restoring blood flow can cause more problems. That still seems so counterintuitive.
It is, isn't it? This is the reperfusion injury. See, when oxygenated blood rushes back into tissue that's been starved of oxygen, it actually creates harmful molecules called oxygen-free radicals.
Okay.
Plus, those bacterial toxins that leaked through the damaged wall. They get spread further by the restored circulation. This can trigger severe body-wide issues like DIC-disseminated intravascular coagulation, a life-threatening clotting disorder,
Oh, wow.
ARDS, acute respiratory distress syndrome, severe lung injury, or even sudden dramatic drops in blood pressure and cardiovascular collapse. So yeah, fixing the initial problem doesn't guarantee safety. The body's reaction can be just as dangerous.
Man. Okay, so now we understand what happens when flow is cut off. What actually causes the flow to drop in the first place? What are the different reasons someone might get mesenteric ischemia?
Right, so the sources break it down into three main types based on the cause. The most well-known and often the most sudden and dramatic is acute mesenteric ischemia, or AMI.
AMI. Acute.
Yep. This is a sudden, severe interruption of arterial blood flow.
And what stops that flow so abruptly? A blockage.
Most often, yes, it's a blood clot. It can be an embolism,
Okay.
where a clot forms somewhere else in the body, often the heart, breaks, travels downstream, and lodges in one of the gut arteries.
Like plumbing blockage.
Exactly. Or it can be a thrombosis, where a clot forms directly in the mesenteric artery itself, usually because the artery is already narrowed by atherosclerosis hardening of the arteries.
Yeah, okay, so existing damage makes it more likely.
Definitely. These are frequently linked to underlying conditions like, well, advanced age, low blood pressure states, severe heart valve problems, irregular heart rhythms like atrial fibrillation.
AFib, right?
Yeah, or even a recent heart attack.
So problems with your heart or general circulation can essentially send a roadblock downstream to your gut. Makes sense.
Precisely. Less commonly, AMI can also be caused by something physically compressing or blocking the artery from the outside, things like trauma, maybe adhesive bands from prior surgeries.
Scar tissue.
Scar tissue, exactly. Or even in rare cases, medical devices used during procedures.
Huh. But you also mentioned a type of AMI where there isn't actually a physical blockage in the main artery.
That's right. That's non-occlusive mesenteric ischemia, or no-nomi.
No-nomi.
Non-occlusive.
Yep. In these cases, the main arteries are wide open, but the blood flow is still critically low. Why? Because of severe body-wide issues causing very low blood pressure or severely reduced overall circulation. It's linked to conditions like severe heart failure, overwhelming infection sepsis, kidney failure, shock, or even, interestingly, certain medications.
Medications. That's a really surprising detail. What kind of medications could cause that? Yeah, it's something to be aware of. The sources highlight several that can contribute to NOMI by causing vasoconstriction, basically making blood vessels clamp down. This includes things like digitalis, ergotamines, cocaine definitely, norepinephrine, and even some common diuretics.
And diuretics, like water pills.
Exactly.
Right.
If your overall circulation is already struggling, these drugs can sometimes make the gut vessels constrict just enough to tip it over the edge into ischemia.
Wow. Good to know. Okay, that covers the acute types.
Yeah.
What's the second main category?
That's mesenteric venous thrombosis, or MVT. This is where the clot forms in the vein draining the intestine, rather than the artery supplying it.
So on the outpipe, not the endpipe.
You got it. And it's the least common cause of acute mesenteric ischemia overall.
And why would a clot form in the vein there?
Well, it can be primary, meaning honestly we don't find a clear cause, or it can be secondary to a huge variety of underlying conditions. The list is really long and diverse.
Like what?
Things like trauma, sepsis, conditions causing high pressure in the liver's portal vein system, like cirrhosis, and particularly conditions that make blood more likely to clot, hypercoagulable states.
Hypercoagulable states,
Yeah.
like inherited conditions.
Yeah.
Genetic stuff.
Yes, exactly. Like genetic deficiencies in proteins that regulate clotting, such as protein CS deficiency or factor V Leiden mutations.
Okay.
But they can also be acquired from other things, like using oral contraceptives, having cancer, sickle cell disease, smoking, being immobile for long periods, using steroids, or even inflammatory bowel disease.
Wow, that is a broad range. It really shows how many different things can impact this.
It really does. does. It highlights how systemic issues can affect this very specific part of your circulation.
Okay. And the third category?
That's chronic mesenteric ischemia, or CMI. This isn't usually a sudden event, but a problem that develops over a long time.
Chronic. Makes sense.
Yeah. It's almost always caused by advanced atherosclerosis, that hardening and narrowing of the mesenteric arteries due to plaque buildup, gradually reducing blood flow over time. It becomes insufficient, especially when the gut needs more blood.
Like after eating.
Exactly, just like after you've eaten a meal.
So similar to the acute arterial problem with atherosclerosis, but it's been brewing slowly for years.
Precisely. Other less common causes include things like damage from radiation therapy, external compression of the arteries.
Like structural issues.
Yeah, like in celiac compression syndrome or median arcuate ligament syndrome. Also, inflammatory conditions of the vessels themselves, vasculitides like polyarteritis nodosa, or abnormal artery development like fibromuscular dysplasia.
Okay.
CMI is often seen in people with the same risk factors as widespread peripheral vascular disease. Age, high blood pressure, and smoking are really big ones.
All right, we've mapped the plumbing, seen what goes wrong, and learned the different reasons why. Now, for the really crucial part. How do doctors actually spot this, especially when time is so critical? What are the signs and symptoms you should be looking for?
This is absolutely where the challenge lies, because it often presents in, well, sneaky ways. First off, knowing the risk factors is essential for prevention, right?
Right.
So if you have conditions like cardiac arrhythmias, advanced age, states where your heart isn't pumping strongly, widespread atherosclerosis, conditions that make your blood clot easily, severe heart valve disease, or a recent heart attack, you're at higher risk.
So primary prevention really means managing those underlying heart and blood vessel issues, keeping your blood pressure, cholesterol, blood sugar in check.
And absolutely not smoking.
Definitely.
Couldn't agree more. But when it comes to the actual acute event, the symptoms are where it gets complicated. And this is where you hear that phrase repeatedly. Pain out of proportion.
The hallmark symptom mentioned in the sources. I remember that.
Yes, it's the classic description for acute mesenteric ischemia, especially the arterial types. It's a rapid onset of severe, just excruciating abdominal pain, often centered around the belly button area periumbilical.
Okay.
But here's the kicker. When the doctor physically examines the abdomen, the findings often seem relatively mild compared to the patient's reported level of agony.
So they're in agony, but the belly feels okay-ish.
Initially, yeah. They might be screaming in pain, but their belly might not be rock hard or dramatically tender everywhere at first.
That sounds incredibly confusing for a doctor. No wonder it gets missed.
It really is, and it's a huge reason why diagnosis is so often delayed. Other symptoms with AMI can include nausea, vomiting, sometimes a sudden forceful need to empty the bowels, confusion or changes in mental status, and tragically, in later stages when tissue is dying, maybe even a distinctive odor on the breath described as feculent, kind of like stool.
Oh, grim. What about no-my, the non-occlusive type? Is the pain different there?
No-my is even trickier. Pain might be completely absent in up to a quarter of patients.
No pain at all.
Sometimes, yeah. Particularly if they're already very ill, maybe sedated, or have altered mental status due to other conditions. When pain is present, it varies greatly in intensity, location, character, much less clear-cut.
Okay. And the vein clot, MVT?
Mesenteric venous thrombosis pain can also be diffuse, sort of spread out across the abdomen, not localized to one spot. It's typically moderately severe and can be constant or come in waves, like colicky pain.
And also out of proportion.
Yes. Like AMI, it's often described as disproportionate to the physical exam findings. Patients might also report diarrhea, maybe some blood in their stool, nausea, vomiting, chills. Sometimes the pain is milder at first and develops over days, or in some cases, patients can even be initially asymptomatic, depending on where and how big the clot is.
Right. Okay, let's switch to the chronic type, CMI. How does that typically show up? Different pattern?
Very different pattern.
Yeah.
The classic symptom for chronic mesenteric ischemia is abdominal angina.
Abdominal angina. Like chest angina, but in the gut.
Exactly. Just like chest pain, angina with exercise means your heart isn't getting enough blood flow when it's working hard. Abdominal angina means your gut isn't getting enough blood flow when it's working hard, which is after you eat. So the pain typically starts within about 30 minutes of eating, gets worse over the next 1 to 3 hours as digestion is underway, and then slowly fades as the digestive load lessens.
So it's predictable pain linked directly to meals. That must be awful.
It is. And because eating causes such predictable pain, a very common consequence is food fear.
Food fear.
Yeah. Patients consciously start eating less or even avoid food altogether to avoid the pain. This leads to significant and often quite rapid weight loss.
It makes sense. They'd be scared to eat.
Totally. They might also experience chronic diarrhea, nausea, vomiting, constipation, or feel full very quickly after starting a meal, what's called early satiety.
Beyond what the patient tells you, what might a doctor find during a physical exam? Any clues?
Well, in CMI, you might see someone who looks significantly underweight or wasted. The medical term is cachectic because of that chronic food fear.
Okay.
In acute cases, you'll look for signs the body is in serious trouble systemically. A high white blood cell count, leukocytosis, acid buildup in the blood, acidosis, low blood pressure, hypotension, maybe a fever, and often very high lactate levels.
Lactate. That's a key marker for lack of oxygen, right?
Exactly. It shows tissue isn't getting enough oxygen. Examining the abdomen might reveal swelling or distension, tenderness to touch. And if there's significant tissue death and inflammation, you might get signs of peritonitis, like rigid abdominal muscles, or rebound tenderness.
But you said that might be subtle early on.
Yeah, the sources note that rigidity can sometimes be less pronounced early on, especially in acute arterial blockages, which adds to the confusion. Listening with a stethoscope might reveal absent bowel sounds in severe acute ischemia. Or sometimes in CMI, you might hear a whooshing sound, a bruit, over the abdomen because of the narrowed arteries.
Sure.
And checking for irregular heart rhythms is crucial, especially in NOMI, as that could be the source or a contributing cause of low flow.
Does age play a big role in who gets this?
Yeah.
Is it mainly older people?
It's often thought of as a disease of older adults, yeah.
Mhm.
Commonly seen in people in their 60s and 70s. But younger patients absolutely get it too.
Oh, really?
Definitely. Though usually due to different underlying causes. In younger individuals, you'd think more about things like collagen vascular diseases, vasculitis, that inflammation of blood vessels, hypercoagulable states we talked about.
The clotting issues.
Right. Use of drugs that constrict vessels like cocaine, or anatomical issues causing external compression of the arteries. Different picture usually.
Okay, so you have a patient with a suspicious history and symptoms, maybe some risk factors.
Yeah.
How do doctors move from suspicion to actually confirming the diagnosis, especially ruling out the dozens of other things that cause severe abdominal pain?
That is the core challenge, absolutely. And the sources make it clear that many initial tests are focused on excluding those more common causes first. Rule out the usual suspects.
Makes sense. What about blood tests?
Blood tests are key indicators of stress and damage. You'll often see that high white blood cell count, the leukocytosis, acidosis where the blood pH is dropping, and importantly, those elevated lactate levels signaling tissues starving for oxygen.
Okay.
The sources also mention some experimental tests, things like alpha-GST, IFA-BP, Sakiba, ischemia-modified albumin. These are still being studied, really, but they represent areas of research trying to find earlier, more specific blood markers for gut ischemia, maybe future tools.
Interesting. What about imaging the abdomen?
Yeah.
Like x-rays or scans?
Right. Standard non-invasive imaging can help rule out other things first. An ultrasound might look for gallbladder issues.
Yeah.
A CT scan might check for kidney stones or appendicitis. An echocardiogram, an ultrasound of the heart, can help identify if there's maybe a clot in the heart that could have broken off and traveled. Endoscopy or colonoscopy can help rule out things like bleeding ulcers or inflammatory bowel disease. Or maybe directly diagnose ischemic colitis if the ischemia is just limited to the colon lining. But they aren't typically used to diagnose widespread acute mesenteric ischemia and can even be risky, actually, in acute venous clots.
I remember reading about a classic finding on old barium studies.
Yeah.
Something about fingerprints.
Yeah, thumbprinting. On a barium study, the swelling and bleeding in the bowel wall creates these indentations that look like thumbprints pressing in. It's a classic visual, yeah. But it's not specific just to ischemia. You can see it in other conditions, too. Plus, barium can interfere with the test that's really considered the gold standard for arterial problems.
Which is?
Angiography. But often the very first imaging step is just a simple, plain abdominal X-ray.
And what does that show?
Well, here's an interesting point the sources make. Sometimes the absence of any clear findings on a standard X-ray, despite the patient being in excruciating pain, can itself be an early warning sign of severe acute ischemia.
So a normal x-ray with terrible pain is actually a red flag.
It can be, yes. Later X-ray signs like seeing gas bubbles actually visible in the bowel wall itself, that's pneumatosis intestinalis, or even gas in the veins leading to the liver, the portal vein. Those indicate extensive tissue death and carry a very, very grim prognosis.
Okay, so X-rays aren't usually diagnostic for the ischemia itself early on, but can show late-stage dire signs. What imaging is most definitive then?
Okay, so for mesenteric venous thrombosis, MVT, the vein clot, a CT scan with IV contrast, is considered the gold standard. It's highly accurate, around 90%.
Wow.
And it can show things like thickening of the bowel wall, the actual clot within the vein, lack of normal enhancement of the bowel wall with the contrast dye, and sometimes that abnormal gas in the bowel wall or portal vein.
Okay, CT for MVT. What about chronic ischemia, CMI?
For CMI, Doppler ultrasonography can be a good initial screening tool. It uses sound waves to look for narrowing in the arteries. But its accuracy really depends heavily on how skilled the person doing the scan is, the sonographer, and it can be limited by things like bowel gas, obesity, or scar tissue from previous surgery.
Right. And you mentioned angiography is the gold standard for arterial issues, both acute and maybe chronic.
Yes, for arterial problems, angiography is generally the gold standard. It's an invasive procedure where dye is injected directly into the arteries while X-ray images are taken.
Yeah.
It provides the most detailed view of the arteries, letting doctors see blockages, narrowings, or stenosis, or areas of spasm. The sources even mention a vivid sign of severe arterial spasm, sometimes seen on angiography, called the string of sausages sign.
String of sausages.
Yeah, because you see alternating constricted and dilated segments of the artery. Angiography can also sometimes help diagnose MVT by showing delayed filling or filling defects on the venous side during the later stages of the dye study.
Beyond those standard imaging tests, were there any more specialized ways mentioned in the sources to assess if the tissue is actually alive or dying, like during surgery?
Yes, a few less common or newer techniques are mentioned, often used during surgical exploration or in specific evaluation contexts. Things like tonometry, which measures the acidity level inside the gut lumen after a meal acidity can increase with ischemia. Endoscopic visible light spectroscopy, to measure oxygen saturation directly on the bowel lining during an endoscopy. And fluorescein-assisted laparoscopy.
How does that work?
Well, a special dye, fluorescein, is injected into the bloodstream, and then surgeons look at the bowel under UV light during surgery. Healthy, perfused tissue glows brightly, while dead or ischemic tissue remains dark. It's a way to visually assess viability.
Wow, okay, so diagnosis is clearly this complex puzzle. Patient history, exam findings, blood tests, targeted imaging, often ruling out other things first. Once this difficult diagnosis is made, how is it managed? What are the treatments?
Right. Management depends entirely on the cause, how severe it is, whether there are signs of tissue death already, and of course, the patient's overall condition. The absolute first rule is, if there are any signs of peritonitis, that infection or inflammation spreading in the abdomen, which usually indicates dead bowel, surgery is the immediate priority. No delay.
Got it. Surgery first if things look really bad. But often, initial management starts with medical support.
Yes, exactly. The absolute first step is optimizing the patient's overall circulation and blood pressure. This means giving IV fluids if they're dehydrated, supporting their heart function if needed, and crucially, you stop or avoid any medications that could be making things worse.
Like the digitalis or diuretics we talked about.
Exactly. Stop anything that could be constricting blood vessels or lowering blood pressure. You also correct any acid buildup in the blood, the acidosis. Start broad-spectrum antibiotics proactively because of that risk of bacteria leaking from the gut.
Makes sense.
And typically start anticoagulation, like heparin, to prevent existing clots from getting bigger or new ones from forming.
What about nutrition, if they can't eat?
Good point. Yes, if the patient is malnourished, has severe diarrhea, or it's expected to be a long course, they'll usually start hyperalimentation, that's nutrition given directly into the bloodstream via IV. Monitoring lines are placed to keep a very close eye on vital signs and pressures, and usually a tube is placed through the nose into the stomach, an NG tube, to keep the stomach empty and reduce the risk of vomiting or aspiration.
And the sources specifically mentioned avoiding certain things initially, besides those meds.
Yes. Strong pain medications, like narcotics, are initially avoided if possible.
Why is that? They're in terrible pain.
I know, it sounds counterintuitive again, right? But it's unless the diagnosis is certain and the surgical decision has already been made. The reason is that narcotics can mask those crucial physical exam findings, particularly signs of peritonitis, which are the triggers for immediate surgery. You don't want to hide those signs.
Okay, that makes sense. What else to avoid?
And laxatives or cathartics are avoided because increasing bowel activity could potentially worsen damage or even cause a perforation, a hole, in compromised tissue. For NOMI specifically, medications that relax blood vessels, like papaverine, might be given directly into the artery via angiography to try and counteract the spasm or constriction.
Okay, what about trying to break up a clot without surgery?
Mm.
You hear about clot busters, thrombolytics.
Right. Thrombolytic therapy using drugs to dissolve a clot can be an option for acute arterial emboli or thrombi, but the window is very tight.
Okay.
It's generally considered only for patients whose symptoms started within about 8 hours, and crucially, who do not have any signs of peritonitis.
Okay.
And even then, if they try thrombolytics and the patient doesn't improve significantly within a few hours, or if their symptoms or signs get worse, they have to switch immediately to surgical or maybe endovascular intervention.
Endovascular, like going in through the blood vessels.
Exactly. And speaking of that, if the issue is a narrowing from chronic disease like CMI, is there a non-surgical way to open that up?
Yes. For chronic mesenteric ischemia caused by narrowing, stenosis, percutaneous transluminal angioplasty, or PTA, is a common non-surgical option.
PTA, like a balloon.
Exactly. A balloon is used to open up the narrowed artery, often followed by placing a stent, like a little scaffold, to help keep it open. The sources note that this avoids major surgery, lower cost, and can have success rates comparable to surgery.
But is there a downside?
Yeah, restenosis, the artery narrowing again over time is definitely a risk, and that might require repeat procedures down the line.
Okay. So when is surgery absolutely the only option?
Surgery becomes necessary when there are clear signs of bowel necrosis tissue death, or if the patient just doesn't improve or worsens despite those initial medical or endovascular attempts. Those signs would be worsening abdominal pain, development of rebound tenderness or rigidity, or signs of systemic collapse like dropping blood pressure. And what happens during the surgery itself? What do they do?
Well, it depends on the cause and how much damage there is. If there's an acute clot, a surgeon can perform an embolectomy or thrombectomy to directly remove it. If parts of the bowel are already dead, non-viable, those sections absolutely have to be removed. That's called resection.
How do surgeons tell, like right there on the table, if a section of bowel is alive or dead?
It's a critical judgment call. They rely on several visual cues. Color dead bowel is often dull gray or black, not healthy pink. Appearance, it might be swollen and distended. And crucial functional checks. Is the bowel twitching or contracting at all? That's peristalsis. And is there blood flow visible, or can they detect it with a handheld Doppler probe on the tissue surface?
What if they're not sure? If a section looks borderline?
Yeah, that happens. If there's any uncertainty about the viability of the remaining bowel ends after removing a section, the sources suggest the most conservative approach is often to bring the ends to the surface as stomach openings on the abdomen and plan a second look procedure 12 to 24 hours later.
Go back in later.
Exactly. Go back in to reevaluate the tissue once the patient is more stable and see if it's recovered or declared itself non-viable.
Okay. And if the main problem is a blockage in a major artery, that can't just be pulled out, like in chronic ischemia or some acute cases with underlying disease.
Right. Then the focus is on revascularization, restoring blood flow around the blockage. The most common surgical procedure for this is an aortomesenteric bypass.
Bypass, like for the heart.
Similar concept, yeah. They create a new path for blood flow, usually using a graft, from the aorta, the body's main artery, to the mesenteric artery beyond the blockage, essentially bypassing the problem area. The sources cite pretty high success rates for these bypass grafts.
Any other surgical options for that?
Another option is a mesenteric endarterectomy, where the plaque buildup is directly scraped out from the inside of the artery. But it's considered more technically demanding and potentially riskier than a bypass.
After they do a bypass or an endarterectomy, how do surgeons confirm it actually worked, that blood is flowing again?
Good question. They'll check the pulse in the artery they fixed just by feeling it. They'll use a continuous wave Doppler probe to listen for blood flow signals. They might measure oxygen saturation directly on the bowel tissue with a little clip-on pulse oximeter. Or they can use that fluorescein dye technique we mentioned earlier. Seeing the dye light up the bowel tissue confirms blood flow has been restored properly.
Wow, quite a process. Beyond the high-tech medical and surgical procedures, the sources also touch on the absolutely vital role of nursing care for these incredibly complex patients. What are the key areas there?
Oh, nursing management is absolutely multifaceted and critical. It involves meticulous monitoring of vital signs and fluid balance. These patients can become dangerously hypotensive or dehydrated very, very quickly. Maintaining their body temperature is important too. Managing bowel function is a big one, especially potentially severe irritating diarrhea from the mucosal damage, which requires vigilant skin care to prevent breakdown.
And pain.
Pain control is a constant challenge because, as we've said, ischemic pain is so severe. So it involves careful, ongoing pain assessment and utilizing both medications effectively and trying non-invasive pain relief methods alongside them.
What about preventing other complications?
Exactly. Continuously assessing tissue perfusion by monitoring their overall status, urine output, mental status, skin color. Preventing infection is paramount, especially with that compromised gut barrier potentially leaking bacteria. And maintaining their nutritional status is critical, whether they're getting IV nutrition initially or eventually transitioning carefully back to eating. These patients require really intensive, high-level nursing care across multiple body systems.
Given how serious and complex this whole condition is, what's most important for patients, or frankly, anyone listening with potential risk factors to know? What are the key takeaways for living with this risk?
Well, prevention really starts with lifestyle, doesn't it? Quitting smoking is huge. Managing hypertension, hyperlipidemia, high cholesterol, and diabetes through diet, exercise, and medication is critical if those risk factors are present.
Right. For someone who has experienced mesenteric ischemia or had an intervention like angioplasty or surgery, recognizing the symptoms of reocclusion, the blood flow getting blocked again, is incredibly important. They need to know what to look for so they can seek help immediately if it happens.
Knowing those warning signs.
Absolutely. And then basic things like proper wound care if they've had surgery and ensuring they meet their nutritional needs during recovery are key teaching points for home care.
This really brings us to a case study mentioned in your sources that pulls so many of these threads together. It describes a 62-year-old woman who arrives at the emergency room late in the day, around 5 p.m. She reports that she developed severe abdominal pain much earlier that morning, right after breakfast, around 7 a.m.
Okay.
Her medical history includes heart failure and an irregular heart rhythm, a dysrhythmia, and she's on medications including digitalis and furosemide. Yeah, it's a scenario that unfortunately highlights the typical delays and complexities we've been talking about. Severe pain starting many hours before presentation, coupled with a history of cardiac issues that put her at high risk for clots or low flow states.
So based on her story and history, what kind of findings would a doctor likely expect on a physical exam when she finally gets there?
Right. With severe pain starting that morning, hours ago, you'd anticipate her abdomen might be swollen, distended. Bowel sounds could very well be absent if the ischemia is significant by now. You'd definitely expect to find tenderness when touching her abdomen. If mucosal damage has started, there might be occult blood, microscopic blood in her stool sample. And as the ischemia progresses and irritates the abdominal lining, the peritoneum, you might well see signs of peritonitis like abdominal rigidity or rebound tenderness where releasing pressure causes more pain.
And those medications she's taking, digitalis and furosemide. The sources specifically point to discontinuing those immediately. Why is that so important here?
Oh, this is a fantastic example of connecting those dots we discussed earlier. Digitalis is a medication that can cause vasoconstriction. It makes blood vessels narrow. And furosemide is a powerful diuretic, a water pill, which can easily lead to dehydration and hypovolemia, low blood volume. Both of these effects directly worsen mesenteric ischemia. Digitalis constricts the already struggling gut arteries, and furosemide reduces the overall blood pressure and flow needed to push blood through those potentially narrowed vessels. Stopping them is absolutely critical to try and improve perfusion.
Makes total sense.
Yeah.
Beyond the severe out-of-proportion pain she's reporting, what other subjective symptoms would she likely have mentioned?
Well, given the potential for gut damage and dysfunction, she would very likely report nausea and maybe vomiting. Diarrhea is common. If she's becoming sicker systemically due to the pain or early toxins leaking, changes in her mental status are possible, confusion, lethargy. And in a late presentation like this, after so many hours, that unsettling feculent odor to the breath might even be present if there's a significant bowel compromise.
Okay, so she's in the ER, high suspicion for acute mesenteric ischemia. What would be the initial medical management steps, even before they have a definitive diagnosis from imaging?
Right. You'd immediately work to optimize her body's overall function. Give IV fluids aggressively to improve her blood pressure and perfusion. Stop those problematic medications immediately, the digitalis, the furosemide. Draw labs urgently to check for acidosis and high lactate, and start correcting them if present. You give broad-spectrum antibiotics right away to cover for potential bacterial translocation from the gut.
Okay.
Initiate anticoagulation with heparin to try and prevent any clot from getting worse. Likely start 5E hyperalimentation for nutritional support since she won't be eating. Insert monitoring lines, arterial line, central line maybe, to closely track her pressures and status. And place an NG tube to decompress her stomach.
And
crucially, you'd initially avoid narcotic pain medications if at all possible, to preserve the ability to accurately assess her abdomen for those evolving signs of peritonitis, and avoid cathartics that could stress the bowel.
Got it. And if those initial steps don't lead to rapid improvement, what are the next steps? Or importantly, what might not be an option in her specific case, given that timeline?
This is where that delay becomes so critical, because her severe pain started way back at 7 a.m., and she's only presenting at 5 p.m. That's 10 hours later. She's already well outside the typical 8-hour window where thrombolytic therapy dissolving the clot non-surgically is usually considered potentially viable.
So clot busters are probably out.
Very likely out, especially if there are any developing signs of peritonitis. Endovascular treatments like angioplasty might be debated if she was deemed extremely high risk for surgery and definitely had no peritonitis, but they're often controversial in acute occlusion cases with long delays.
So surgery seems more likely.
Much more likely. Surgical options would be an embolectomy or thrombectomy if imaging shows a removable clot. However, as the sources point out, acute thrombosis often happens in an artery that's already narrowed by chronic disease.
Atherosclerosis.
Right. Which means revascularization, like performing a bypass surgery, is frequently needed in addition to just removing the clot. And sadly, given the significant delay and the high potential for tissue death over those many hours, bowel resection surgically removing dead segments of intestine is very likely going to be necessary as well.
Whoa.
Yeah. The case starkly illustrates how the passage of time really forces different, often more invasive, and unfortunately often less successful treatment choices.
That case study really brings home the urgency and the cascading decisions involved. What a journey. We've gone from the delicate network of arteries and veins supplying the gut through the devastating sequence of events when flow is compromised.
Yeah, the ischemia and reperfusion.
Explored the diverse triggers from clots to medications, wrestled with the huge challenges of diagnosis and those often misleading symptoms.
Especially that pain out of proportion.
Exactly.
Yeah.
And finally, seen the complex landscape of medical and surgical interventions where every hour truly matters.
It's absolutely a condition where every hour counts, and as we've discussed extensively, spotting it early is incredibly difficult because its signs can mimic so many other, often less severe, abdominal problems.
Understanding that hallmark symptom, that severe pain that just doesn't seem to match what the doctor is finding on examination, and being aware of the major risk factors, especially if you or someone you know has a history of heart issues or clotting problems, feels like an absolutely crucial takeaway from this.
Indeed it is, and it leaves us with perhaps a critical question for you, the listener, to ponder. Given the significant challenges in achieving a rapid diagnosis and the potentially catastrophic outcomes if it's missed or delayed, how can we as a healthcare system, and perhaps even as individuals aware of the risks, improve the ability to recognize and intervene for this devastating condition within those crucial few hours that make all the difference?